So before we proceed to the drugs for the gastrointestinal tract, let us first know what is the gastrointestinal tract. So the gastrointestinal tract or the GI tract is a series of hollow organs that form a long continuous passage from our mouth to our anus. So the organs that make up our GI tract are our mouth, esophagus, stomach, small intestine, large intestine, and anus. So what is the peptic ulcer disease? So the peptic ulcer disease or the PUD refers to a group of upper GI disorder characterized by varying degrees of erosion of the gut wall, which usually occurs in the stomach and proximal duodenum. So the ulcers which occur inside the stomach are called the gastric ulcers. On the other hand, the ulcers which occur in the inside of the upper portion of the small intestine or the duodenum are called the duodenal ulcers. What causes the peptic ulcer disease? So the most common cause of peptic ulcers are infection with the bacteria called Helicobacter pylori or H. pylori, and the long-term use of non-steroidal anti-inflammatory drugs or NSAIDs such as ibuprofen and naproxen sodium. The Helicobacter pylori is a gram-negative bacillus that attacks the lining which protects the stomach and colonizes the stomach and the duodenum. So on the other hand, NSAIDs or the non-steroidal anti-inflammatory drugs inhibit biosynthesis of prostaglandins, which promote secretion of gastric acid, decrease submucosal blood flow, suppress secretion of mucus and bicarbonate, and irritate mucosa directly. So this results to the developing of ulcers. Before we proceed to the drugs for peptic ulcer disease, let us watch a brief and very comprehensive video about how ulcers develop in our body.
What is an ulcer? An ulcer is a wound which penetrates through the layers of the stomach through the muscularis into the submucosa. An ulcer develops usually over a background of chronic gastritis, for example, due to an H. pylori infection. A long-term infection will result in ulcers. So there are two types of ulcers: gastric ulcers, which occur in the stomach, and duodenal ulcers, which occur in the duodenum. Right. So before we discuss the pathogenesis of ulcers by H. pylori, let's discuss a bit about the normal physiology of acid production in the stomach. There's a specific type of cell called G cells in our stomach. These G cells will produce something called gastrin, which is a hormone. This gastrin hormone is very important as it stimulates the parietal cells in the stomach to produce and secrete the hydrochloric acid or gastric acid. There's another type of a cell which is called D cells or delta cells. These delta cells will produce something called somatostatin, which is a potent inhibitor of this gastrin production. So basically, somatostatin is important to reduce the acid production in our stomach. But what H. pylori does is it destroys these D cells or these delta cells, which in turn will decrease the somatostatin production in our body. This will ultimately cause the regulation of acid production in the stomach to go haywire because now there is no mechanism to decrease the acid production in our stomach. So when there is increased acid production in the stomach, there is a huge chance for inflammation to occur, which could lead to erosion and ultimately lead to the ulceration in the stomach or wounding of the stomach lining. Also, you know that the stomach dumps all its contents into the duodenum after digestion. So the same case will happen when stomach produces more acid. It will dump all that acid into the duodenum. So that's when we get duodenal ulcers. It's also important to know that not only H. pylori but also NSAIDs or non-steroidal.
The drugs used for treating the PUD or the peptic ulcer disease are the antibiotics and the anti-secretory agents. For antibiotics, we often use clarithromycin, amoxicillin, bismuth, tetracycline, tinidazole, and metronidazole. And for the anti-secretory agents, we have histamine 2 receptor antagonists or H2RAs and the proton pump inhibitors or the PPIs. So for the antibiotics, clarithromycin or suppresses growth of the H. pylori by inhibiting protein synthesis, and in the absence of resistance, treatment is highly effective. And for the amoxicillin, Helicobacter pylori is highly sensitive to amoxicillin. So amoxicillin kills bacteria by disrupting their cell wall. For bismuth, it is composed of compounds such as bismuth subcilate and bismuth subcitrate. It acts topically to disrupt the cell wall of the H. pylori, thereby causing lysis and death. Bismuth may also inhibit urease activity and may prevent H. pylori from adhering to the gastric surface. So the tetracycline is an inhibitor for bacterial protein synthesis, which is highly active against H. pylori. The other two antibiotics are the metronidazole. It is very effective against sensitive strains of H. pylori. Metronidazole should not be taken during pregnancy, and taking it again with alcohol must be avoided. For the tinidazole, it is very similar to metronidazole, and they share same drug adverse effect and interaction. Like metronidazole, tinidazole can cause a disulfiram-like reaction and hence must not be combined with alcohol. For the 4 histamine 2 receptor antagonist, we have cimetidine. It reduces volume of gastric juices and basal acid. It is taken orally. Ranitidine suppresses secretion of gastric acids, more potent and fewer adverse effects and drug interactions than cimetidine. It is taken orally and through intramuscular and intravenous. So for famotidine, it is approved treatment and prevention of duodenal ulcers. It is administered through oral and intravenous. Nizatidine is it treat and prevent duodenal ulcers. It is taken also orally. So the most common PPIs or the proton pump inhibitors is the omeprazole. So omeprazole and other PPIs reduce 24-hour acid secretion by 90% compared with 65% of histamine 2 receptor antagonist, and acts faster than H2RAs to reduce gastric acidity and relieve ulcer symptoms. It is taken orally. Other anti-ulcer drugs. Sucralfate. It promotes healing of ulcers by creating barrier against pepsin and acid. It attached to the ulcers, which lasts for 6 hours. It is administered orally. For misoprostol, an analog of prostaglandin E1, it prevents NSAID-induced ulcers by serving as replacement for endogenous prostaglandins. It is taken orally. For the antacids, it is an alkaline compounds that neutralize stomach acid and use of neutral salts to decrease destruction of gut wall and reduce pepsin activity. It is taken orally. The laxatives. So before we proceed to the laxative drugs, let us first define and know the functions of the colon. So the principal function of the colon is to absorb water and electrolytes. If the colon is working correctly, the stool is soft and capable of elimination without strain. But when the fluid absorption is excessive, stool is dehydrated and hard, while conversely, if insufficient fluid is absorbed, results to watery stools. Constipation. So constipation is defined in terms of symptoms, which include hard stools, infrequent stools, excessive straining, prolonged effort, a sense of incomplete evacuation, and unsuccessful defecation. But constipation is determined more by stool consistency or degree of hardness than how often bowel movements can occur. So what is laxative? Laxatives promote defecation. Legitimate indication for laxatives include cardiovascular disorders, episiotomy, hemorrhoids, emptying bowel before surgery, and diagnostic procedure such as ileostomy or colostomy, prevention of fecal impaction in bedridden patients, and constipation associated with pregnancy and certain drugs, especially opioids, analgesics. The basic pharmacology of laxative. So first, the bulk-forming laxative. It absorbs water, which thereby softens and enlarging the fecal mass that cause fecal swelling, which promotes peristalsis. So, peristalsis is the involuntary movement that occurs in our digestive system. It is a series of wave-like muscle contraction that move food through our digestive tract. So the second laxative is the surfactant. It acts on softening stool by facilitating penetration of water into the feces and lowering surface tension. Also cause secretion of water and electrolytes into the intestines. So next is the stimulant laxative. So stimulates peristalsis, softens feces by increasing secretion of water and electrolyte into the intestine and decreasing water and electrolyte absorption. So the osmotic laxative. The osmotic acts on retaining water and thereby softens the feces and fecal swelling, which also promotes peristalsis. Just a trivia or a fun fact. Laxative was used in some as a way to lose weight by taking laxative to defecate or to release their waste, but not in a healthy way. So the laxative abuse. So laxatives are commonly misused and abused by the public. Strong laxatives or continuous usage of it can purge the entire bowel. So chronic exposure to laxatives can diminish the defecatory reflexes and leading to further reliance on laxatives. So as we use the laxative, we regain or we tend to rely on it as we go along, because as we think that if we didn't drink the laxative, we feel constipated. That's why we continue to use it, and we became dependent on it, dependent on the laxative. So the laxative abuse may cause dangerous pathogenic changes, including electrolyte imbalance, dehydration, and colitis.
So what are the other gastrointestinal drugs? So I will be discussing some assortment of G1 drugs with indication ranging from emesis to colitis to hemorrhoids. So there are 4 groups are emphasized. First is the antiemetics. Second is the antidiarrheals. Third is drugs for irritable bowel syndrome. And last is drugs for inflammatory bowel disease. So first, I will be discussing drugs under antiemetics. So antiemetics are given to suppress nausea and vomiting. So there are several types of antiemetics are available, and serotonin receptor antagonists are the most effective drugs available for suppressing nausea and vomiting caused by crispapine and other highly hematogenic anti-cancer disease. So for the first drug under antiemetics drugs, which is ondansetron. So this drug is used to prevent nausea and vomiting associated with radiotherapy and anesthesia. Administration may be oral or parenteral. So the most common side effects are headache, diarrhea, and dizziness. So in addition, this drug is used off label to treat nausea and vomiting from other causes, including childhood viral gastritis and morning sickness of pregnancy. Our next drug, which is the glucocorticoids, and there are 2 drugs under this, which are the methylprednisolone and the dexamethasone. So these drugs are commonly used to suppress CINV, even though they are not approved by the U.S. Food and Drug Administration for this application. So administration for glucocorticoids are effective alone in combination with antiemetics. For our next drug is the netropitan. So this drug is available only in combination with palonicetron and is marketed as Akenzeo. Their principal application is prevention of CINV. An example of prototype of this drug is aprepitant. Our next drug is the aprepitant. So this drug is an important antiemetic. The drug is approved for preventing post-operative nausea and vomiting and CINV. So oral aprepitant is well observed both in the presence and absence of food. And aprepitant may cause a mild transient elevation of circulating aminotransferases, indicating possible liver injury. So this drug can also enhance responses when combined with other antiemetic drugs. Our next drug, which is the lorazepam, it is used in combination of regimens to suppress CINV. The drug has 3 principal benefits: sedation, suppression of anticipatory emesis, and production of anterograde well-tolerated amnesia. In addition, lorazepam may help control extrapyramidal reaction caused by phenothiazine antiemetics. For our next drug is the phenothiazines. These drugs can reduce emesis associated with surgery, cancer, chemotherapy. For our next drug, which is the phenothiazine, these drugs can reduce emesis associated with surgery, cancer, chemotherapy, and toxin side effects include extrapyramidal reactions, anticholinergic effects, and hypotension and sedation. It also suppresses emesis by blocking dopamine receptors in the CTZ. For our next drug, which is the butyrophenons, these drugs are used as antiemetics like the phenothiazines,
The butyrophenol suppress emesis by blocking dopamine receptors in the CTZ. So butyrophenols are effective against post-operative nausea and vomiting, and emesis caused by cancer chemotherapy, radiation therapy, and toxins. So potential side effects are similar to those of the phenothiazines, extrapyramidal reactions, sedation, and hypotension. Next is the metoclopramide. This drug suppresses emesis through blockade of dopamine receptors in the CTC. The drugs can suppress post-operative nausea and vomiting, as well as emesis caused by anti-cancer drugs, opioids, toxins, and radiation therapy. Our next drug, which is the cannabinoids, and there are two drugs under this, which are the dronabinol and nabilone sesamet. So these drugs are approved for medical use in the United States. And both of these drugs are related to marijuana. So nabilone is a synthetic derivative of dronabinol, and dronabinol is the principal psychoactive agent in C. sativa. Motion sickness can be caused by sea, air, automobile, and space travel. Symptoms are nausea, vomiting, pallor, and cold sweats. Drug therapy is most effective when given prophylactically rather than after symptoms begin. So, for the next slide, I will be discussing some drugs that can be take if you are having motion sickness. Drug, which is the scopolamine. It is the most effective drug for prevention and treatment of motion sickness. So the most common side effects are dry mouth, blurred vision, and drowsiness. So scopolamine is available for oral, subcutaneous, and transdermal dosing. For our next drug, which is the histamines, used most often for motion sickness are dimenhydrinate, meclizine, and cyclizine, because these drugs block receptors for acetylcholine in addition to receptors for histamine. Other side effects are dry mouth, blurred vision, urinary retention, and constipation result from blocking muscarinic receptors. So antihistamines are less effective than scopolamine for treating motion sickness, and sedation further limits their utility. So diarrhea is characterized by stools of excessive volume of fluidity and by increased frequency of defecation. Diarrhea is a symptom of GI disease and not a disease first. Causes include infection, maldigestion, inflammation, and functional disorders of the bowel. Example, irritable bowel syndromes. So for the next slide, I will be discussing some drugs some drugs to take when you are having diarrhea. So for our first drug, we have the opioids. These drugs decrease intestinal motility and thereby slow intestinal transit, which allows more time for absorption of fluid and electrolytes. Next drug is the diphenocylate. So this drug is insoluble in water and hence cannot be abused by parenteral routes. When taken orally and antidiarrheal doses, diphenocylate has no significant effects on the CNS. However, if taken in high doses, the drug can elicit typical morphine-like subjective effects. Next drug is the loperamide. It is a structural. Next drug is loperamide. It is a structural analog of meperidine. The drug is employed to treat diarrhea and to reduce the volume of discharge from ileostomies. Benefits derive from suppressing bowel motility and from suppressing fluid secretion in the intestinal lumen. So the drug is poorly absorbed and does not readily cross the blood-brain barrier. Next drug is the diphenhoxine. So it is the major active metabolite of diphenhoxylate. Like diphenhoxylate, diphenhoxine can elicit morphine-like subjective effects at high doses. Next drug is the paregoric. It is a Next is the paregoric. It is the dilute solution of opium. containing morphine as its main active ingredient, and the primary use is for diarrhea, although paregoric has the same approved use as morphine. Next is the opium tincture. Is an alcohol-based solution that contains 10% opium by weight. The primary indication is diarrhea. In addition, this drug may be given to suppress symptoms of withdrawal in opium-dependent neonates. Next drug is bismuth subsalicylate. It is effective for the prevention and treatment of mild diarrhea. Users should be aware that the drug may be blacken stools and the tongue. Next drug is the anticholinergic antispasmodics. It can relieve cramping associated with diarrhea but do not alter fecal consistency or volume. However, owing to undesirable side effects, example, blurred visions, photophobia, dry mouth, urinary retention, tachycardia, anticholinergic drugs are off-limited. Next is irritable bowel syndromes, or IBS. Is the most common disorder of the GI tract. A GI disorder characterized by crampy abdominal pain, sometimes severe, occurring in association with diarrhea, constipation, or both. For our first drug, we have the allosetron. This drug is approved only for the treatment of women with severe IBS that has lasted for 6 months and more, that has not responded to conventional treatment. And administration is oral, and absorption is rapid but incomplete, 50 to 60% level. Although allosetron is generally well tolerated, it can cause severe adverse effects. Deaths have occurred, and the most common problem is constipation, 29%, which can be complicated by impaction, bowel obstruction, and perforation. Our next drug, we have the lobiprostone. The drug can reduce abdominal pain and discomfort, but only in a small percentage of patients. Efficacy against IBS-C in men has not been established, and the most common adverse effect is dianthine, which has been severe in some patients, leading to dehydration, hypovolemia, and hypotension. Inflammatory bowel disease, or IBD, has two forms. First is the Crohn's disease and ulcerative colitis. Crohn's disease is characterized by transmural inflammation. It is usually affect and terminal ileum, but it can also affect all the other parts of the GI tract. Ulcerative colitis is characterized by inflammation of the mucosa and submucosa of the colon and rectum. Both diseases produce abdominal cramps and diarrhea. For our first drug, we have the sulfasalazine. Its only approved indications are IBD and rheumatoid arthritis. Sulfasalazine is most effective against acute episodes of mild to moderate ulcerative colitis. So responses are less satisfactory when symptoms are severe. Sulfasalazine can also benefit patients with Crohn's disease. Adverse effects are nausea, fever, rash, and arthralgia are common. Next drug is mesalamine. This drug is used for acute treatment of mild to moderate HD and for maintenance therapy of IBD. Mesalamine can be administered by retention enema, by rectal suppository, or by mouth, in tablets and capsules that dissolve when they reach the terminal ileum. So the most common side effects of oral therapy are headache and GI upset. Next drug is the oxalazine. This drug is approved for maintenance therapy of ulcerative colitis in patients who can tolerate sulfasalazine. And the most common adverse effect is water diarrhea, which occurs in 70% of patients. Other adverse effects include abdominal pain, cramps, acne, rash, and joint pain. Oxalazine is supplied in 250 mg oral capsules. Next drug is the balsalazine. It is an aminosalicylate indicated for mildly to moderately active ulcerative colitis.
The most common adverse effects are headache, abdominal pains, diarrhea, and nausea. So, balsalazine is available in 750 milligram oral capsules sold as Colasal, and 1.1 GM tablets as sold as Biazo. Next drug is the glucocorticoids. This drug can relieve symptoms of ulcerative colitis and Crohn's disease. Benefits derived from anti-inflammatory actions. Glucocorticoids are indicated primarily for induction of remission, not for long-term maintenance. And administration is IV or oral. Next drug is the oral budesonide. This drug is approved for mild to moderate Crohn's disease that involves the ileum and ascending colon. Immunosuppressants are used for long-term therapy of selected patients with ulcerative colitis and Crohn's disease. Clinical experience is greatest which azathioprine and mecaptopurine. Next drug is the thiopurines. These drugs are discussed together because one is the active form of the other. Major adverse effects are pancreatitis and neutropenia, secondary to bone marrow suppression. Next drug is the cyclosporin. This drug is a stronger immunosuppressant than azathioprine or mercaptopurine and acts faster too. When used for IBD, the drug is generally reserved for patients with acute severe ulcerative colitis or Crohn's disease that has not responded to glucocorticoids. So there are 6 drugs that monoclonal antibody products that modulate immune responses. 3 of these drugs, infliximab, certolizumab, and adalimumab, are inhibitors of tumor necrosis factor alpha TNF. So I will be only discussing drugs under infliximab. The first drug, we have the natalizumab. This drug integrin and thereby impedes migration of leukocytes from the vasculator into areas of inflammation. The drug is approved for Crohn's disease and multiple sclerosis. So the pharmacology of natalizumab, including its dosage for Crohn's disease. Next drug is the ustekinumab. This drug is for the treatment of moderate to severe Crohn's disease in patients who fail to respond to therapies previously listed. Ustekinumab is a monoclonal antibody that blocks activity of interleukin 12 and interleukin 23. These interleukins cause inflammation both independently and through stimulating the production of TNF. Next drug is the metronidazole. The dosages employed up to 750 mg 3 times a day are high. Furthermore, because relapse is likely if metronidazole is discontinued, long-term therapy is required. Although metronidazole can help patients with Crohn's disease, benefits are minimal in those with ulcerative colitis. Next is the ciprofloxacin. It is highly effective in patients with mild or moderate Crohn's disease, like metronidazole. Ciprofloxacin is of little benefit in ulcerative colitis. Prokinetic drugs increase the tone and motility of the GI tract. Indications include gastroesophageal reflux disease or GERD, CINP, and diabetic gastroparesis. Next drug is the metoclopramide. This drug suppresses emesis by blocking receptors for dopamine and serotonin in the CTC. Also, this drug increases upper GI motility by enhancing the addiction of acetylcholine. With high-dose therapy, sedation and diarrhea are common. Long-term high-dose therapy can cause irreversible tardive dyskinesia characterized by repetitive involuntary movements of the arms, legs, and facial muscles. Next is the palifermin. It is the first drug to be approved for decreasing oral mucositis or OM, a serious and painful complication of cancer chemoradiotherapy, but only applicable for patients with hematologic malignancy, and then only in those receiving high-dose chemotherapy and whole-body irrigation to eradicate cancer cells before a hematopoietic stem cell transplant. Our gallbladders serve as a repository for bile, a fluid composed of cholesterol, bile acids, and other substances. Cholelithiasis, development of gallstones is the most common form of gallbladder disease. Most stones are formed from cholesterol. Stones made of cholesterol alone cannot be detected with X-rays and hence are said to be radiolucent. Chemodial, the drug naturally occurring bile acid that reduces hepatic production of cholesterol. Reduces cholesterol production, lowers the cholesterol content of bile, which in turn facilitates the gradual dissolution of cholesterol gallstones. Dose-dependent diarrhea occurs in 30% to 40% of patients. For our last drug, we have the ursodiol. This drug is an analog of cannabidiol. Like cannabidiol, ursodiol reduces the cholesterol content of bile, thereby facilitating the gradual dissolution of cholesterol gallstones. So this drug is classified in FDA pregnancy risk category B.